Hello and welcome to Westwind, an audio podcast about cancer, technology in medicine, and policy issues. I'm host and medical oncologist Dr. Jack West from the City of Hope Comprehensive Cancer Centre in the Los Angeles area. You can find Westwind material at BeaconMedIC, one word.com, at iTunes, or just about anywhere you get podcast content. I would just ask that you show your interest and support by subscribing, commenting, sharing by telling friends and colleagues in person and on social media, and rating it however you feel is appropriate. You can also share your ideas and opinions by emailing us at westwindpodcast@gmail.com. I'm very happy to be joined today by Dr. Ben Solomon, who is Professor of Medicine at Sir Peter MacCallum Cancer Centre, Department of Oncology at the University of Melbourne in Australia. Ben, thanks so much for taking the time.
Thanks for the invitation, Jack.
Now, you've heard some of my podcasts. I think you know I like to get into the origin story for our medical superheroes. And you have a quite interesting one, because I don't think you, even though I think of you as being from Australia and having deep roots there, that's not where you actually were born and raised.
That's right, Jack. I've had the privilege of living in 4 different continents as I've grown up, and I consider myself in some ways a citizen of the world in that regard, although I really do call and feel very lucky to call Australia home. So I was born in Sri Lanka, but at the age of 2, my family left Sri Lanka and we moved to Zambia, which is in Central Africa. And I did my primary schooling in Zambia, and then my family moved to Australia, where I did my secondary schooling and went to university and trained in medicine.
Can you tell us about what led to the moves, both to Zambia and then to Australia?
Yeah, so a lot of people in Sri Lanka moved out of Sri Lanka because of tensions that eventually actually erupted into civil war in Sri Lanka, and my parents were fortunate in having professions that they were able to find jobs outside Sri Lanka. And my dad is an accountant, my mum a dentist, and they made a very early decision that this was a place that would be challenging to bring up a family. And like a lot of South Asian people from Sri Lanka and India, they planned eventually to move to countries such as the US or the United Kingdom or Australia. We ended up in Zambia and had a great time there for 10 years. I went to a school which was an international school. Most of the teachers there were actually from the US or from the UK. And at the age of about 11, my parents decided to apply to immigrate to Australia, and we moved to Melbourne. And I've been based in Melbourne since then. But I have had the opportunity to work in the United States, having done my medical training and trained as a medical oncologist. I did a postdoctoral fellowship in Colorado and got to live with my wife in the United States for 2 years, which was a fabulous time of our lives. We thought we would travel a lot around the US when we were in Colorado, but Colorado was such an amazing state that we found stuff to do every weekend and absolutely loved our time there.
So do you ski?
I did not ski when I got to Colorado, but after 2 Colorado winters, I was quite comfortable on black runs. Having moved back to Australia, where snow is not great, I think my ski legs have atrophied somewhat.
Now, did you always have an interest in medicine, or did that come later in your life?
I remember always being interested in science, and I remember. Actually, when I was very little, visiting my uncle, who was a professor in Iowa, of all places. And I remember he gave me a book, which was a book about astronomy by Carl Sagan. And I was pretty young at that time, but I think that sort of was a reminder to me that science was something that I was always fascinated by. And medicine was a way to pursue that interest. And so in Australia, you go straight from high school to university and to a medical degree. And I was 16 at the time, and naively I thought that medicine would be a great way to learn about science. And I was just very fortuitous that I loved everything about medicine, and that sort of allowed me to pursue a career in thoracic oncology, where I get to combine clinical research with some laboratory research, and it worked out very well for me, largely through luck rather than planning, I think.
Now, you have a PhD and an interest in bench work as well as clinical work. Obviously, many physicians don't pursue a PhD or have that interest. So how has your focus evolved from your initial entry into medical school to getting a PhD, doing a postdoc, and your subsequent work? How do you balance the clinical and the basic science, and how do you see that evolving over time?
I think it can certainly be challenging to combine clinical work and clinical research with laboratory research, but I think there are all sorts of different ways to do it, and there is a broad spectrum that really needs people to populate all aspects of that spectrum. And I find clinical research is my passion, but I think the laboratory research is a way to really leverage that clinical research through translational work with patient samples, with biomarker analyses. So it's a natural fit for me to combine the lab work with the clinical research. I think it also, the time that I spent in the lab really gave me time to step away a little bit from, I guess, the coalface of clinical medicine, to think more about the big picture of the problem we face when we're dealing with cancer. And I think it's helped frame clinical questions that we can try to answer through clinical trials. So I think it's complementary, and I encourage people who are interested in doing some lab work or even a PhD, which is outside the lab, and there are opportunities for that to do it, because I think it can help the way you think about medicine and help whatever aspect of medicine you choose to end up in.
Mm-hmm. You said you were with your wife in Colorado. Did you meet her there, or is she Australian, American, Sri Lankan?
So my wife is Tasmanian. She's from Tasmania, and so she's Australian. You could probably trace her heritage back to the First Fleet, English origin. So we met actually while I was doing my PhD in Melbourne. She's not a medical person. She's a science PhD. So in many ways, we ended up in Colorado largely because of my wife. So when we were both choosing where to go for postdocs, she went on her tour first, and she went to Colorado and New York and Boston and a few other places. And then I'd scheduled to do my tour afterwards. And so I asked her, what did you think? Where would you like to go? And she said, look, I'll go anywhere where you want to go, but I really like Denver. So I really had no choice, and as it turned out, I really had a great visit to Denver, and I had a great visit to the other places that I went to as well. But it worked out really well for both of us, and it was a good life experience. I think living in another country is a fantastic thing, particularly for we're a new couple, and it sort of allowed us to develop our relationship away from home as well. And it also, I think, makes you appreciate what home is and what home means. So we loved our time in Denver, and I could have easily stayed in the US. But when a job came up at Melbourne, it really felt the right thing to go back home. Mm-hmm. And it's been great that our kids get to be around their grandparents. And I think going away teaches you lets you appreciate home more. Yeah.
So you still have family in Melbourne. That's great.
That's right. My parents are in Melbourne. My wife's mother lives in Tasmania, and she visits us quite frequently, so we're very lucky to have our kids' grandparents actively involved.
How many kids do you have?
I've got two kids, two boys, aged 10 and 12.
That's great.
So it's a great age, and having lots of fun.
Excellent. Do they ever come on any of your travels? Or, I mean, one thing that always strikes me about Australia is if you leave, it's a very long distance to anything.
It is a long distance, and they are used to me going away traveling. And I remember my younger boy saying that he wanted to be an oncologist. This was sort of right after astronaut and fireman, and I asked him, why do you want to be an oncologist? And he said, because you get to travel and see the world if you're an oncologist. And I guess he is partly right. It is really a privilege of our profession that as part of our core work, we get to travel to meetings like WCLC, meet with fantastic colleagues like yourself, Jack, and hear about great science and form new collaborations. And I'm not sure there are too many other professions where the sort of stuff which is really enriching scientifically, but also personally is a core part of what we do.
Mm-hmm. How did you get into lung cancer in particular within the field of cancer care?
Yeah, that's a great question. I think the very first patient that made me really think about cancer was a young woman who had been diagnosed with a pleural effusion. And I was just a year and a half out of medical school, and I remember being really pleased that I was able to drain the pleural effusion, and the chest X-ray showed no fluid. But then I read about the prognosis of malignant pleural effusions. The cytology came back adenocarcinoma, and how dismal this lady's outcome was based on what was known about malignant pleural effusions. And I think I will always remember that patient. And then I went on to do my oncology training, and I think you are influenced by the people you work around. And when I was a trainee, I got to do lung clinic with people like David Ball, who are fantastic mentors. Mentors like David Ball, a medical oncologist called Danny Rishin at Peter Mac, and they really encouraged me to pursue a career in medical oncology and in particular lung cancer. So it really just felt like a good fit for me, and it's turned out to be something that I'm passionate about, that I enjoy, and I find highly rewarding and challenging at the same time.
It's interesting that over the time that you and I have been doing thoracic oncology, it's really changed a lot in terms of the outlook for patients, from one where certainly I was asked, and you may have as well been asked, why did you go into lung cancer? As if it was under duress because it was such a challenging diagnosis. Not that it isn't challenging now, but we've had so many advances, and you in particular have been central in a lot of that work. But now we have patients routinely living years, and we can even ask whether we might be curing patients who are alive 5+ years beyond the start of their treatments, which was unthinkable 15 years ago, for instance, 15 or 20. How do you think about the changes that have happened? And really it's been amazing. But with that, we've gone from seeing lung cancer as a monolithic population to more and more granular in terms of narrow populations defined by molecular features.
Yeah, no, I think amazing is a good word, Jack, to describe what we've seen in the last 15, 20 years in lung cancer. I remember at the time that I started doing lung clinics, and the same time you started doing lung clinics, it was pretty unusual to see a patient in clinic who had been alive more than a year. A couple of weeks ago in our lung clinic at Peter Mac, a patient brought a cake in, and the cake had 10 years living with advanced lung cancer. And that was a fantastic celebration of really what we'd seen in the last 10 or 15 years. This gentleman had an ALK rearranged lung cancer and was was in fact the first patient we put on the crizotinib phase 2 trial, and he's subsequently on alectinib and doing really well. He's seen his son go from high school, graduating from college, and we're seeing more of these patients who are living 5-10 years. And you're right, it is granular, but it raises new challenges. And the challenges are, why can't we get those other patients to live that long? And why don't all patients get to celebrate these fantastic anniversaries? So the granularity, but even is one thing, and identifying the molecular subtypes, but also finding how we can improve outcomes in patients who don't have those molecular subtypes. Immunotherapy has been a big step in that direction, but we still have the situation where the majority of patients don't benefit from immunotherapy. And how can we keep lifting the bar? So we've made progress. There's still plenty of progress that we need to make.
How much of a challenge do you see it as translating some of the advances at the tertiary care centers of excellence where the research is being done, Peter Mac, Memorial, MD Anderson, the Harvard system, and I'd like to think City of Hope as well. But there are the tertiary care centers, and there's challenges in executing some of these advances beyond that in the broader communities, certainly in the US, and maybe you can speak to that in Australia as well, because it's just not feasible to have everyone come to a handful of centers to all get their cancer care there.
Yeah, that's an important question, and I think translating research into practice and broad practice is a field in itself. How do you implement changes across a community, and probably an area which hasn't got as much attention as it deserves. We know that there's a problem there, but we're not very good at going about fixing it. I think part of the challenge is the issue of molecular testing and making sure that people do get accurate characterization of their cancers. I think access to treatments is another issue, and this is a global issue. There are drugs that get approved in certain countries which are not available in other countries or available after delays. So there's sort of issues at a sort of national or international level, and then there are issues that you mentioned between the sort of academic centres and community practice. I think education and getting oncologists who treat all cancers to be aware of these amazing advances and referring patients for trials, for making sure they get tested is part of the issue.
One interesting development that I think has been a kind of side effect of narrower and narrower subgroups, such as EGFR and ALK, is that many of these patients find each other online, have aggregated, and become an important, valuable force to be reckoned with. And I think the ALK positive group online is a key example of that. They get on planes and go on trials. What is the patient community like in Australia? Is what we see in the US a largely global phenomenon of these patients becoming galvanized and feeling like part of a global community, or is the kind of proactive approach that we see, at least in the US, somewhat regionalized and less so in Australia, for instance?
Yeah, so we're doing this podcast from the World Conference on Lung Cancer in Barcelona, and I've seen walking through the halls several patients and patient advocates from Australia. So it truly is a global community. We're seeing patients who are very engaged, as you say, communicate with other patients through Facebook groups. My understanding is to get on those groups, you pretty much need to show your ALK FISH report or NGS report. So I haven't pried to see what's on those groups, but I think they're very informative for patients. They're amazing. We sometimes we get patients coming in and telling us about amendments that are going through on trials, going through IRBs that they've heard about from other patients. So I think information is power, and I think they're incredibly positive forces. I think lung cancer is an area which for a long time has suffered from a lack of advocacy, has suffered from issues related to stigma as well. And I think patient advocacy and the patient groups are an important way of turning that around.
What do you see as some of the biggest imminent future advances in lung cancer over the next 2, 3, 5 years? Do you see, for instance, next-gen sequencing becoming essentially universal, or is the availability of tissue or the time issues going to be a limiting factor for that? Is liquid biopsy going to become very commonplace, or will immunotherapy become ideally, or let me ask that again, or will immunotherapy potentially become an effective treatment for more than the more limited subset we see now?
I think we're going to see precision medicine or personalized medicine go to a next level. And what I mean by that is we're getting better and better at identifying oncogene targets. And I think we will see, and we're already seeing movements into oncogenes like RET and NTRK. And there probably maybe a few, I'm not sure how many more of those we'll find, but I think we'll start to move into personalization of immunotherapy. We'll get better at selecting patients for immunotherapy. We'll move towards things like personalized neoantigen vaccines, where tumors are sequenced, unique neoantigens are identified, and vaccines that are unique to individual patients that are designed and used as therapies. I think that's the sort of next generation of personalized medicine. I think also we'll move away from the sort of set and forget approach. So what I mean is, rather than starting a patient on a drug and leaving them on the drug until their scans show progression, we're going to use tools like liquid biopsy to monitor how things are going, to try to anticipate and deal with resistance as it emerges, and prevent a clinical event of progression by identifying it potentially earlier and before it becomes clinically manifest through things like liquid biopsy.
I've been very interested in the still early but very consistent converging work, and not just in lung cancer but in several kinds of cancer, that looking at circulating tumor DNA can give us some insights about the likely future outcomes, some early feedback on whether a treatment is working, whether patients are likely to have a recurrence. Of course, cost is an issue. The availability of the test is a big appeal. I mean, it's being able to draw blood and from any clinic and get the results back in a matter of days is, I think, very attractive, but needs to be feasible from the terms of cost, and also has to be something that is going to impact clinical outcomes meaningfully.
That's right. And so I think because of those issues, because of cost and as you say, needing to impact and having meaningful clinical impact, I think it's important that we take a thoughtful approach to implementing these strategies. And I think we need to design trials to show benefits of these approaches before we do it. And that's challenging because of the sort of, I guess, the multiple different permutations and combinations that can come up in the situation of evolution of resistance. And you can truly have N=1 cases of changing a therapy and improving an outcome. And how you show and prove the health economic benefit of doing that, I think, is really challenging. But I think with the expanding cost of oncology care across all modalities, I think we do need to think about these issues early rather than late.
Well, certainly, as many of our cancer drugs are costing what used to be a threshold of $10,000 a month, and now that seems quaint, and it's $20,000, $25,000 a month. Figuring out which patients don't need as much treatment, whether it's selecting patients better for or not to get adjuvant therapy, or which patients can stop immunotherapy and be watched. If we could prevent some of those treatments that we don't know if it's necessary, we just do it as a ritual or to be conservative, That $20,000, $25,000 a month for many of these, being able to deselect some of those patients could be an effective value there.
Absolutely, completely agree.
Well, Ben, thank you so much for taking the time. Really enjoy catching up with you. Given that we're, a couple of time zones away, it's challenging to get together, but I love it when I do get to see you.
Thanks, Jack. It's been a delight chatting with you as always.
Thanks for listening. The West Wind Podcast is a Beacon Medical Interchange production with sound engineering and distribution by Mark Lindsay of Talking Speaker. We hope you'll be motivated to subscribe, whether at BeaconMedIC.com, through iTunes, or through another podcast service. Please also rate it, and I hope you'll be inclined to tell friends and colleagues in real life and on social media. We're always happy to get your suggestions and other input at westwindpodcast@gmail.com. Talk to you again soon.